Good evening, everybody. Thank you very much. First of all, I would like to thank the organizing committee for the invitation to participate in this very interesting Congress. And please accept my apologies for not being able to join you in person today. Let me share my presentation with you. Can you see my screen?
Yes, now we see.
Okay, so in the following 10 minutes, I will talk on the basic anatomy of the normal mitral valve and share the basic information on mitral valve anatomy with you. As we all know, mitral valve is a complex structure and the understanding of the
Μαρία, συγγνώμη λίγο. Μπορείς να πατήσεις τις ρυθμίσεις εμφάνισης για να το έχεις σε full screen, αν γίνεται.
Το έχω σε full screen.
Το πρώτο πάνω, αναλλαγή προβολής παρουσιαστή. Okay.
Βλέπετε την οθόνη μου?
Τέλεια, αυτό ακριβώς. Ωραία.
Okay. So the understanding of the anatomy of the mitral valve is crucial for the best patient selection and the success and the evolution of mitral valve transcatheter interventions that we're going to discuss about today. Starting from the formation of the AV valves, this comes early in gestation between the 5th and the 8th week of gestation. Four cushions develop the AV junction, and later on, the superior and the inferior cushions will meet and divide the AV orifice, forming later on the two AV valves. The papillary muscles and the chordate tendina are derived from the trabeculations of the ventricle. So, what are the components of the mitral valve apparatus? The annulus, the leaflets, the tendinous cords, the papillary muscles, the atrial and the ventricular wall, as well as the mitral aortic continuity known as aortomitral curtain. So we are going through all these structures today. First of all, the mitral annulus is part of the fibroskeleton for the attachment of the valvular tissue, the atria and the ventricle. It's disc-shaped with a curved part in the posterior part of the annulus and a straight part in continuity with the aortic valve. So the posterior segment of the annulus is formed by different structures as the atrial wall, the leaflet hinge line, the marginal free wall of the LV, and adipose tissue, connected by a fibrostring which is not continuous, making the posterior part of the ring of the annulus more sensitive to calcification and dilatation. Going on to the straight border, the interior part of the annulus, this accommodates the aortic valve. And here we see the aortic mitral curtain, which is an area, a fibrous area that connects the anterior mitral valve leaflet with the aortic valve, So the end of this structure, at the end of this structure, there are two rigid structures, the right and the left fibrous trigons that are contiguous with the IVS, the intraventricular septum, the non-coronary cusp at the right side, and the left coronary cusp at the left side. The mitral valve annulus has a 3D saddle-shaped appearance, and it's dynamic. It's moving, and its circumference varies significantly during the cardiac cycle. Going on to the mitral valve leaflets, there are two leaflets, the anterior one, which is almost square. It occupies 1/3 of the annular circumference, and it has common attachment to the cardiac skeleton with the left coronary cusp and half of the non-coronary cusp. It's virtually divided into 3 scallops, the A1, A2, and A3, while the posterior leaflet is smaller It occupies 2/3 of the annulus and also has 3 scallops, the lateral P1, a middle P2, and a medial P3. When we see the mitral valve leaflets, there are two different areas. A rough one that starts approximately 1 centimeter from the distal leaflet edge and receives the insertion of the cordia tendineae, and a clear one, which is smoother, thinner, and it's lacking any portal insertion. In systole, the leaflets go up in a height of 8 millimeters approximately. So this is a coaptation reserve in cases when we have annular dilatation. Moving on to the tendinous cords, these are fibrostrings that originate from the papillary muscle tips. They insert into the ventricular aspect of the leaflets and are classified according to the position of the insertion of into the leaflets. Into marginal cords, which are thinner, they insert into the leaflet tips, and the basal cords, which are more thick, and they are more extensible because they tend to be tighter collagen structures. The papillary muscles. 2 papillary muscles, one anterolateral, which is attached to the lateral LV wall. It is larger, and one smaller one, posterior medial, attached to the posterior LV wall. The anterolateral papillary muscle has dual blood supply from the circumflex and the LAD, while the posterior medial one is usually supplied either by the circumflex or the right coronary artery, which makes it more sensitive to ischemia. There are different types of papillary muscle morphology. One common classification is this one in this graph. Type 1, one single head. Type 2, 2 heads, one of which sends cordia exclusively to the posterior leaflet. Type 3, divided with one head supporting the commissural area exclusively, and a fourth one with different heads that originate at different levels of ventricular wall. But we should not forget about the neighboring, the adjacent structures to the mitral valve apparatus. One of them is the coronary sinus. It encircles the posterior mitral valve annulus. The anatomy is variable, and it's the distance to the mitral valve annulus is greater in cases of significant mitral regurgitation due to the dilatation of the annulus. And we have to keep in mind that the circumflex coronary artery is in close proximity to the coronary sinus. So, in conclusion, the mitral valve apparatus is a very complex structure, and the understanding of the anatomy of the mitral valve apparatus and its surrounding structure is crucial for the correct selection of patients, the procedural success, and the further development of mitral valve transcatheter interventions. Thank you very much.
A presentation. So are there any comments, any questions from the audience? So maybe we can have a question. So Dr. Uberlakis, before doing your mitral minimal invasive procedure, do you always screen a CT or a CMR? Is there a place in surgical procedures?
Yes, because I mean, when we do endoscopic procedures, we need to have a good CT scan, chest and upper and lower abdo, because we need to have a look at what's happening with the peripheral vessels as well. But I really enjoyed this talk because it gives us how much variety there is in terms of papillary muscle heads and artificial cords, and I think this makes a big difference, especially even if we're talking about transcatheter treatments, and even if we talk about surgical treatment and repair of the mitral valve. Sometimes we end up having too many papillary heads in front of us and too many strings of artificial chordae, or sometimes things are quite clear and we have a nice area at the area of P2 and A2 and makes my life and probably the life of interventional cardiologist as well easier. So knowing the anatomy of the mitral valve and seeing what you see on the echo and what you probably can imagine what's happening in the operating field, we are luckier because we can see the valve in front of us, so our life is much easier. But we need to have an idea with TOE. I think it makes a great, it's very important.
Excellent. Dr. Kotroulou?
Except for the CMR that Dr. Boutsikou very nicely presented to us the anatomy, it's very, very important that we always start with the echocardiogram. Things that are abnormal, such as, for example, the parachute mitral valve. It's something that, of course, the surgeons need to know. Maybe there is only one papillary muscle, that it's definitely something that needs to be known before someone goes for surgery or for an intervention. So definitely MRI, TOE, and transthoracic echo before for a good plan is very important. Thank you, Dr. Boutsikou, for your nice presentation.
Good. So thank you, Maria. We have to leave it there because we're a little bit behind.